So in this grant that was funded, was written in 79 and was started in 1980. One of the aspects of designing the study was asking what would be an optimal way to stimulate the patient. And how could we compare two treatments when we didn't know whether we were dosing them appropriately?
ECT for
Right.
electroconvulsive therapy. Yeah.
Right. And the field of ECT believed the provided the necessary and sufficient conditions for efficacy. It didn't matter how you produce a seizure, whether you produced it chemically or electrically. And later in time, when we developed magnetic seizure therapy, you could do it magnetically. But as long as you produced a adequate generalized seizure, you had a potent therapeutic agent. And the biblical view is also that the electricity did not contribute to the efficacy of the treatment, but contributed to the side effects. Right. So, but nobody in the world ever said, how does that translate into practice? Shouldn't I try to give the least amount of electricity possible, but make sure that the person has an adequate seizure? That way I guarantee efficacy and minimize side effects.
Right. So to be clear, you produce the seizure. The seizure is where the clinical benefit comes from, maybe some of the side effects. But as far as the direct effects of electricity, other than producing a seizure, at that time, those were assumed to just all be bad. So the electricity on itself is a bad thing. Only when you get a seizure at this point is something good possible. That was the thinking at the time.
And I realized this fundamental principle, which had some experimental support from Jan Otto Ottosson in Sweden. He had a brilliant set of experiments that were published in 1960 that, 20 years before this work that sort of set the stage. And so the question was, well, how are you going to minimize dose? If you go high and then go down, you have no idea where the threshold for the seizure is, how high above it you're starting, and it could take you forever to get to where you have essentially a subconvulsive stimulation.
Meaning if every patient starts with the dial turned all the way up,
and then you keep chopping it down
on different days. Okay, yes.
Because once you have a seizure, you can't, one of the things that we did know, by the way, is that the seizure itself is anticonvulsant. It raises the threshold for itself. We could maybe talk about that in a bit, but so we decided, thinking through the problem, to go below what would likely be the threshold. I was hoping to maybe have only 15% of people have an adequate seizure at the initial starting dose, a small minority with a very small dose. And because these steps were extremely large, we were essentially doubling the electrical charge at each step in order to try and capture this range.
So is this sinusoid or pulsed? Is this voltage controlled or current controlled at this point?
At this point, it's a brief pulse. It's with a MECTA device. I think it was a Model B. I have a picture of it on my office here. And the guy who had designed this device was a brilliant psychiatrist who had a premature and rather unfortunate death. Paul Blachley, who started the MECTA company, was at University of Oregon. And he was the one that created the first brief pulse device to move away from sine wave, recognizing how inefficient the sine wave was in producing. And he also offered parameters in his very first device that disappeared for decades from the field. He offered a device that produced a 0.15 millisecond pulse width, ultra brief.
Right.
It wasn't until 2008 when we published our ultra brief work and moved the field down to a 0.3 of a millisecond pulse width. And now we've gone back, we just finished a study randomizing to a 0.15. So 50 years later, we're returning to what this guy's inspiration was. He was rafting in the Columbia River with his son when his son fell in the river. He jumped in and saved his son's life, but he drowned as a young man. And the people who now own what is Sigma Stim and previously the MECTA Corporation, at auction bought that company after Blachley's death.
Interesting.
Yeah.
Right,
So,
so you're titrating. Are you
yeah,
titrating intensity? Or are you titrating? Okay, so there's charge, but are you titrating the intensity of the pulses or are you titrating the number of pulses?
uh, excellent question. And we'll come back to that. In developing all of this, we were limited by what the device could do at the time.
Yeah.
The device was totally fixed in terms of its current. So it was a 800 milliamp pulse amplitude. Nothing you could do about it. Nowadays, I argue that the best titration would be in the current domain as opposed to number of pulses. But I had the Mecta Corporation design for us a device, and the parameter that they could change the most and give us more space was frequency. So we had a device from the very beginning that went from 20 hertz to 140 hertz. We doubled essentially the frequency range
Okay.
that it was capable of. My group later went on to show that uh, if you're changing the number of pulses, it's more efficient to change the duration of the pulse train than the frequency of pulses. And
Yeah.
so modern devices, when they're working algorithmically, always increase duration before. We didn't know that at the time. The very first patient we treated was a woman about 35 years old, a school teacher, mother of two, who had been hospitalized at the Psychiatric Institute at Columbia for 9 months,
No.
and she believed she was burning in hell. This was her reality. Before she was referred to us for ECT, she put a rope around her neck and over the old pipes in the old building tried to hang herself. She was randomized. This was a trial in which the trial design was two cells, unilateral, bilateral, for the very first time, giving the least amount of electricity possible at each and every session. This was a trial where we titrated radically. If we found your seizure threshold in the first session, we gave that same dose in the second. And in the third session, if you seized at that dose in the second session, we deliberately went down again. Track seizure threshold throughout people's courses. And that is one of the things that came out of that is in ECT, the threshold for seizure goes up about 60 to 70%, particularly in people who do well.
Mm.
60 to 70% more electricity produces seizure at the end of a course than at the beginning. That's one of the very clear-cut indications that it's anticonvulsant. This woman was randomized to low-dose bilateral ECT, required 4 treatments, and was completely euthymic.
Mm.
A week later, she was back teaching school, and I was impressed.
And that was
I,
also your first ECT.
yeah, I had never seen the procedure before being funded for it.
Okay.
That would not happen nowadays. In those days, they sent the site visit team out if they thought the grant was interesting. The site visitors came and we talked for an afternoon. They said, "Yeah, we'll try it." And,
Okay.
yeah, so that was my first experience with it. And what that study showed, it was published in 1987 in the American Journal of Psychiatry, the clinical results and the seizure threshold findings were published in what's now JAMA Psychiatry, also in 87, same year. And clinically, what happened was right unilateral ECT didn't work at all. It had about a 17% response rate. And whereas the bilateral group had a 70% response rate. Now we had managed to undo the efficacy of right unilateral ECT. And that violated the fundamental principle of ECT because we had the most conservative criteria for what constituted an adequate seizure. And if it were just a seizure
Mm.
was necessary for the efficacy of the treatment, we had managed to produce generalized seizures that didn't work. And that upset the field. That was not just sort of this is a better way or not a better way of doing it, but sort of our understanding is wrong. And
Obviously, that wasn't the death of right unilateral. I mean,
no, no, no. Well, you could go two ways with that. Don Klein, my colleague, who was the head of therapeutics at Columbia, and the at the time the vice chair for research. Don is the father of psychopharmacology, literally. That's his. No. He said, Harold, you must have had a bad randomization. There's no way you could give ECT and have outcomes like that in a group. So that was one explanation, is that
Mhm.
it was bad randomization. The other was that dosage mattered for this treatment. What was a big thing that we changed? We gave bilateral and unilateral just at the seizure threshold.
Okay.
And so just in the second study in that series, we replicated those two conditions. And in every of the 5 ECT studies, randomized studies that we did at Columbia, independent of the multi-center studies we did, we always carried over 2 conditions. But in the next study, there were 4 groups. Were the uh, unilateral and bilateral at just at seizure threshold. And then the same conditions where we turned the dial up 2.5 times. And this is sort of, to me, was one of the beauties of working in brainstem and in sort of the biological bases of psychiatry is that you could do a really clean experiment. You can manipulate things in a very, very direct fashion. And what that study was published in New England Journal of Medicine in 93. And what that study did is it totally replicated the results of the first study, that right unilateral at threshold doesn't work at all. Bilateral at threshold worked the same way, but took longer than bilateral ECT 2.5 times above threshold. There, you got an acceleration of the antidepressant effect when you increase the dose. But with unilateral, you turn many, many more people into responders and remitters. And what it turned out was we had underestimated 2.5 times, I thought, was above the level where seizure threshold is going up during the course of treatment, that we would stay well above that so that we wouldn't, have that problem. But it wasn't enough. In the next study, which was published in what's now JAMA Psychiatry, there were also 4 groups. The 2.5 time threshold groups were retained, and then we did 6 times unilateral and 1.5 times unilateral. And basically, what we found is that at 6 times unilateral, um, it's as efficacious or more efficacious than any other of the groups. That there is a true dose response effect with unilateral ECT. That when you turn the dial up, you get better and better clinical outcomes into the asymptote.
So there's a lot happening here in quick succession that ends up impacting the field for decades and impacting the lives of countless amount of patients. And we just want to pause and talk about it here, right? One is the introduction of, I mean, things that would be taken for granted now, right? But here they are coming up in very quick succession in a very, it's sort of one paper after another, right? I can just see this acceleration of dosing. So we have dose, first of all, the systematic consideration of bilateral versus right. The first introduction of titration, which is done with controlled pulses instead of sinusoidal pulses. And then the realization that even once you have that threshold, you need to be considerate of a multiple of it, right? And that multiple depends on this montage, right? Whether you're bilateral or unilateral. So all this which is now foundation, like canonical, more than right to the field is emerging at this time, right?
Mm-hmm.
So and sets the tone until today. So maybe say more about that, but also I asked you before about how you titrate a dose. So another thing that exists until today is that almost all ECT is done with a fixed current amplitude, which is not typical for any other space in brain stimulation, right? And this
Right.
also um, seems to be a consequence of decisions that you are making in this time period, right? That are just carrying through for decades.
Yeah, I think the field of ECT, to its credit, certainly has moved forward and has accepted evidence. Maybe sometimes to its discredit, it's very slow in doing that, and some of that conservativeness comes from uh, the criticality of the treatment and the disability of the patients, the impairments of the patients. So you can imagine people are very reluctant to change things that they think work. And by then,
And our life saving.
and they're life saving. And so, you know, uh, one of the things we did at this time, to give you an example, is we were the first to ever use ECT to stop status epilepticus. The stories about the first patients to ever have a deliberate seizure induced in them while they're seizing continuously, incredible events, and so on. That is now part of standard guidelines uh, uh, in the treatment of superrefractory status epilepticus. It's all over the place now. But it took 50 years for that to and of course it's obviously counterintuitive.
That approach, well, counterintuitive then, now it became intuitive as a direct consequence of you first titrating threshold, wanting
Right.
to do that, and then tracking how that threshold is changing over time, and then realizing
Right. And what we were
that
able to also do is show that seizures get shorter and weaker in their expression during the treatment if you hold dosage constant. The thresholds go up. If you look at glucose and metabolism and cerebral blood flow, you're getting marked reductions after treatment. Jerome Engel at the time out at UCLA, one of the greats in epilepsy, had published in Science the same sort of thing, that with epileptic seizures, you're seeing in the postictal state, this inhibitory state, presumably tied to the processes that terminated the seizure itself. And so we had the physiology, we had the concrete data on thresholds, and so on. I spent 2 years following patients with epilepsy with the head of outpatient epilepsy at Columbia, because I felt it was wise to really get a better understanding of the effects of seizures on people by being not just with ECT patients, but patients with epilepsy. And it was that connection where we saw patients together and talked about what was happening that led the epileptologist to say, yes, why don't we try this for the first time? I mean, it wasn't just my team's courage to do that. It was really the epileptologist's courage. Stan Reeser was the fellow. The first patient we treated like that was a 18-year-old girl who had grand mal seizures since birth. She wore a helmet because she already had cerebral cicatrix in her CT at the time. This is before MRIs existed. And when we gave her ECT under oxygenation, anesthesia, the full thing, three times a week, she became seizure free of spontaneous seizures. And we did A, B, A, B, A, B. And we showed that after we stopped the ECT, we got epileptic rebound, and then she went back to her baseline rate. And then when we reinstituted ECT, all the seizures went away. And we tracked with Xenon 133, CBF, the changes in her cerebral blood flow in her brain with the ECT and her seizure frequency. I presented that work in Montpellier in a satellite of the International Cerebral Blood Flow Metabolism meeting, an epilepsy satellite, and was almost run out of town. These were people that had devoted their lives to stopping seizure, usually in animal models. And here was somebody who was measuring seizure threshold in the human for the first time and deliberately giving people seizures and so on. So there was a rather frosty reception initially to that sort of thing.
So on this notion of titrating, not titrating to current level, right? And how maybe a bigger theme about when is brain stimulation an innovative field and when does it get locked into something that it gets into locked into some pattern that it can't escape as a consequence of the machines that you were provided at the time, which at the time were innovative, but they did not have built-in ability to adjust the current threshold. You had no choice. You had to adjust thresholding through other means, frequency and number of pulses. And boy, did that stick. And again, I want to emphasize I don't think that exists in any other field of brain stimulation or neuromodulation. In all other fields, I think adjusting current is a go-to, even a starting point. And yet, something that happened back then,
Yeah,
right? Locked the field of ECT in for decades.
yeah. I've written a fair amount about that, and we just had a paper in brain simulation with Ziad Nahas, where we randomized people to a zero point 0.6 amp or a zero point 0.9 amp stimulus. I believe that in the future, titration in the current domain would be a superior way to go. And I think it's a clear-cut issue. Only a small portion of the electrical stimulus actually enters the brain. Most of it is shunted between the electrodes, largely because the impedance of the scalp and brain are extremely low. Um, Whereas the impedance of the skull is around 17,000 ohms per centimeter of depth. And we're talking on the skin in the same units around 200 ohms per centimeter depth. So you're going to have a lot of the stimulus being shunted across the scalp, very little getting in. But how much gets in is going to be function largely of skull anatomy. And so there are two aspects here. What happens is people get different levels of current when depending on their skull anatomy, because that's what's being shunted. Is not the number of pulses. You don't do anything to the timing of pulses in the brain. What you do is you're changing the amplitude of the pulse when you're shunting. And
You're saying different people for the same stimulus current, different people will get a different amount of current into their brain as a result of differences in anatomy and tissue properties.
a great example is females have a lower seizure threshold than males, let's say. And much of the data, we reported that in 1987, much of the data still confirms that. But what do we do with males? We give them more pulses. So the female is having a lower threshold because she has a thinner skull, right? More of the current is actually entering the brain. So it's going to go to a deeper level in the female brain because of the at least the depolarizations will because of the greater amplitude of pulse. And to make up for that, we give a shallower stimulus with more pulses to the male. Makes no sense. And the problem clinically is, I also argue, we don't know where in the pulse amplitude range we want to be in order to preserve the efficacy of the treatment. It's not for instance, the current Sigma device has a current adjustment that you can go from um, 500 to 900 milliamps on it. That's fairly substantial. But we don't know whether you should be at 200 milliamps or 1.2 amps. That what we're shooting for, what the average should be, what is an unknown in ECT, I argue. And the president of a company, Somatics, who make the thymatron, had a paper in out of Germany. They did the study in Germany where they double titrated people, comparing a 900 milliamp stimulus to a 1.125, I believe it was, higher, and claimed that you needed less charge to produce the seizure with the higher than the lower, that ECT devices are under currented, so to speak, in terms of what would be optimal. There are people like Lisenby and others who are arguing that low amplitude is the way to go. And that's largely been motivated because you can't get much juice out of a magnetic seizure approach. That the amplitudes induced in brain are far below what you can achieve with electrical stimulation, and the hope is that if magnetic seizure therapy works, then we can mimic it electrically, and we would go to a low amplitude approach. That's their
But
perspective.
but of course, right, we don't you're titrating based on charge, but ultimately we don't care about charge. It's not like you're trying to save on your electrical bill. It's really about maximizing the efficacy and minimizing the side effects, obviously.
Exactly. And so to do that, you need to know what is the amplitude I need to shoot for, and around that I can titrate. And we still don't have that information. In fact, um, the only study that's ever been done is the one that we did with Nahas that actually charge balanced, gave two stimuli to the same person, one at lower current but with more pulses, the other at higher current and fewer pulses, and asked which is more efficient in inducing seizures, which results in faster orientation recovery, which is a great acute marker of what long-term cognitive effects would be. And
That and the other efforts you talked about, these are in the past years. It's still, there's still the fact that for decades,
well, absolutely,
uh,
you don't have the answer to that to this day. It's a big issue in the field. A lot of the field is now recognizing current would be the way to go for titrating, but nobody is really stepping back and saying, but around where am I going to titrate? It's not just producing a seizure that is going to be consequential, which is going to be the optimal stimulus. So yeah, that's certainly, and it's evident that if you look at vagus nerve stimulation, DBS, not so much TMS, um, um, but some of the other interventions, that they're all adjusting current, essentially maximizing current and being limited by side effects.
you're trying to find that therapeutic window
Right,
first with current,
right.
then with other parameters. So, um, before we get back into the details, as a big picture point, is this as I see it, you're making a lot of the innovations. There's other contributors as well, but a lot, you're carrying a lot of them yourself. Um, why in ECT? Why in other? Is that is this something peculiar about ECT where if you were to line up all the innovations that were made and there's maybe 10 of them, eight of them are Sackeim papers. One person seems to be making so much of an impact. Is that true in other fields? Is that a general issue with medicine? Is there something with brain stimulation where it gets stuck and it takes
I don't
individual disruptors to change things?
have to do brainstem. I think ECT is a peculiar place. Number one, my experimental work with ECT was done at the Psychiatric Institute. There are only two places in America where you could have done that work. The average length of stay of my patients was 3 to 4 months.
Hmm.
These people were washed out of medication. They went through 9 to 5 neuropsych testing before being treated, all sorts of physiological imaging work, and so on. If they failed their first course of treatment, we automatically offered them a second course of ECT. And that's because at the Psychiatric Institute, all the beds are free. If patients had insurance, we didn't accept it. This is like the NIH in terms of it being a true research institute with research patients where there's no financial aspects. And at the time, you can imagine, um, these are very, very sick people, uh, that require, a lot of care. And when you're taking them off of medications, you're limiting their access to benzodiazepines and so on. You can't do it in a lot of places. So that was one thing that because the state of New York uh, provided the support for the patient care where it was free.
Hmm.
That was and also provided the support for a lot of the investigators, people like me and Joan Prudick and many others, the Devon and Lisenby, that was extremely important in terms of our grants being competitive. The other part of it, I think, is political. For instance, nothing like that ever came out of NIH, and never would, because ECT just elicits um, a political nightmare that leads to a dearth of funding. I tell my colleagues sometimes, very few people come home at night and say to their kids, "Hey, I'm a shock doctor." That it carries its own um, level of disregard, at least in the funding process. Um, and then anytime you do research with really, really sick people, where you're doing randomized research and so on, uh, um, it's really very, very hard. You have to have a lot of resources and support to do that. So there's not very much ECT research of going on at the level of RCTs, high quality and so on. Much of what's reported is usually observational.